Great. Well, it's a great pleasure to be here. This is such a special group, and not only are you individuals with a deep and important interest in MPNs, but you clearly are trying to lead an important effort. You're advocating, you're educating, you're helping build patient communities. And indeed, in many ways, the MPN patient community, as we see with our colleagues in CLL, these are special things. What I have found that the ability for patients, for advocates, for the medical community to work together, we accomplish so much more together than we do individually. So really, it's really a great pleasure to be here. Now, for my topic at this year's meeting, I thought I might do something just a little bit different, in that we're covering some of the core items, some of which that you've heard before. What I wanted to focus on a little bit are the things that you hear about kind of in conversation, but don't usually hear too much about. And that's really the rest of the cancer world and how it might relate to MPNs either now or in the future. So there's a lot of research that is going on in parallel in diseases in the blood, diseases which are cancer, both of which can have linkages with MPNs. And I wanted to touch base on a few of those most noteworthy ones so that you understand them a little bit better and also see how close or far they might be from the clinic. So first, let me talk a little bit about cancer. Now, although this is a very emotive word, cancer refers to any disease where we're making cells that we should not be making. And for reasons some people feel comfortable using this word along with MPNs and others don't, from a biology standpoint, there is no question that they fall into this group. Now, if that causes individuals more distress, don't use the word. But in terms of the biology, as folks like Claire and I study it, there is no question that they fall in that category. And there are many lessons that we learn from these diseases, whether they be mild or severe, that are highly relevant. Now, in my day job, I am a cancer center director. So I personally care for MPN patients, but I oversee with several hundred colleagues, physicians, nurses, and scientists, the care of all cancer patients, and are charged with that for San Antonio and South Texas. So that's an area of about 6 million people, and it's an area that's really quite sizable in area. So I think about these issues often. Now, as we think about cancer, there are many ways that we try to study these diseases to understand the weaknesses that we can exploit to better try to cure these diseases. Now, these are just some examples. We have agents which are trying to decrease how cells grow, or what we call proliferative signaling. We have medications that are getting around some of the ways that cancer evades the suppression of growth. We have agents with the immune system that we'll get into in a moment, an area that has transformed care now of many areas, including lung cancer and kidney cancer, melanoma, and others. We have telomerase inhibitors, which is enabling the replicative immortality, and this has some relevance in ET and myelofibrosis. We have issues of inflammation and how we're trying to target inflammation. We have issues of how cancers spread that may or may not be relevant in the end to a disease like this. There is angiogenesis, or new blood vessel formation. There is genome instability and mutation. There is the resistance of cell death, and even cellular energetics. So a whole range of different themes. Now, some of these are more relevant to MPNs than others. One of them is this issue of telomerase. Telomerase is an enzyme that is involved with helping to upkeep our genetic structure. It's an important age-related enzyme. The inhibition of this process may have relevance for individuals with blood-related cancers. Imetelstat, now by Janssen, is a drug that has been shown to have activity both in ET and myelofibrosis. This is ongoing in its studies, and we may hear some more information about these studies soon. This was data from the ET study that showed both the ability to help to control the counts as well as to improve the molecular features of the disease. This is interesting. This is a completely different approach to these diseases, and this is the first drug in that approach. So we look forward to hearing more, but of course, if this is helpful, there's a potential, again, if the approach is helpful, is this the right therapy? Maybe there's other therapies along this approach that may be developed that will be better, either alone or in combination. Each signal we see that is beneficial opens up many questions. Do we use it alone? Do we use it in combination? In whom should we use it? The next that I'll highlight is really the revolution that is immunotherapy. As we think about the treatment of cancers overall, probably the greatest impact over this last several years has been immunotherapy. Now, immunotherapy, we clearly have a very complex immune system that helps us not only to fight infections, but one of the big functions of our immune system is destroying cancer cells. Every day, we form many new cancer cells. We all do, perhaps even millions of them. And our body has this immune system that recognizes these cells when they go bad and they destroy them. I use it very much as a goalkeeper type analogy. For those that watch the World Cup, imagine that poor keeper not having 5 shots on goal, but having 1,000,000. And defending that goal is a key part of the immune system. And it's thought that one of the reasons we might develop a disease is because of really a weakness in that function. The immune system can be so powerful because if we compare it to drugs, one of our most selective cancer drugs in history before, tested first in my center in San Antonio, anywhere in the world, Taxol, is only about 1 in 100, so it's quite selective. An immune-based approach might have a specificity that is infinitely more specific for a disease. Now, why the immune system in cancer? Well, in large part, and there's many complex parts I won't dive into today, but suffice it to say that there are ways that cancer cells disguise themselves from the immune system and are able to escape it. And that's one of the reasons they can take root and really grow. So scientists really look to see how do we make the cancer cells more apparent to the immune system so that the immune system can then destroy the cells involved. And with these, there's a particular area that has been the most impactful. And it refers to an area called PD-1 or PD-L1. These are the names of the receptor and antigen. But basically, the cancer cells are expressing a antigen that is making them more protected against the immune response. And with this, there had been the hypothesis that if you were to block this part or block this checkpoint on immunity, what's called checkpoint inhibition, then the cancer cells will be more visible to the immune system, and the immune system will then help to destroy the cancer cells. This has led to people have looked at a variety of ways now successfully and that have been approved of blocking these checkpoints in immunology so that the patient's immune system is more effectively able to eradicate or shrink or to control a cancer. What you see here are several different places in that pathway that have been blocked and the diseases that now have approvals for medications to do that. The first were in melanoma, but now they include kidney, lung, Hodgkin's disease, head and neck cancer, bladder, colorectal, hepatocellular, on and on. So you're seeing a trend. I mean, this is a revolution in terms of its impact. Now, in myeloid cells, what is it relevant here in MPNs? Well, it turns out that JAK-STAT signaling can lead to an increase in the expression of this same protective factor of PD-L1. And although myeloid cells have differences with some of these other solid cancers that I have mentioned, there certainly is a suggestion that there is a similar thing at play. Now, some of the early approaches to using these exact same medicines in related diseases, acute leukemia and myelodysplastic syndrome, have not yet been successful. But lessons are being learned from that. Maybe there's a different way at getting at this same issue of escaping the immune system. PD-L1 is being looked at in patients with MPNs, and one of my colleagues, Dr. Gabby Hobbs, as well as John Mascarenas from Mount Sinai, are doing a study looking at patients with myelofibrosis with pembrolizumab, individuals who are not on ruxolitinib or cannot be on ruxolitinib, and they are doing a study on this to look at the level of activity. It'll be a natural question as well at some point in the future. If this is helpful, again, how does it combine with the other therapies that we have? Indeed, targeting the immune system has a variety of different ways. In addition to this, there's everything from vaccines that are being developed to other ways to target the immune system against your cells. Now, one of those ways that is probably the most in the news is what we call CAR T therapy. CAR T refers to chimeric antigen receptor genetically engineered and targeted cells. And this was pioneered by really a groundbreaking investigator from the University of Pennsylvania, Carl June, who started looking at this in pediatric acute lymphocytic leukemia patients. In brief, they take T cells from an individual. They are separated. They are kind of trained in the laboratory to go after a specific receptor from an individual's cancer, potentially. And then they are given back to the individual in a process that's fairly intensive. It's not like a bone marrow transplant, but it is a very complex and involved therapy with certainly a significant amount of a process and some side effects that are involved. That being said, it has made a big impact already on certain cancers of lymphoid origin, particularly acute lymphocytic leukemia, lymphoma, and myeloma. Now, what about CAR T and MPNs? This is a question I get asked frequently. So one, this is an interesting therapy. It can be very powerful. It has been powerful mainly against lymphoid diseases. So what do I mean by that? In the blood, all the cells pretty much fall into one of two camps. Lymphoid, so these are lymphocytes. These are related with diseases like lymphoma, myeloma, acute lymphocytic leukemia, and myeloid cells. These include things, the red blood cells, the platelets, neutrophils, and related cells. The majority of the blood are myeloid cells. Myeloproliferative neoplasms are diseases of myeloid cells. Why this is important, with lymphoid cells, we can use therapies to typically diminish the number of those cells very significantly. And people will have a suppressed immune system, but people can survive that process. With myeloid cells, if we take those cells down to a very minimal number, then individuals do not make enough of the cells they need, and that can be very life-threatening. So there's still a technical barrier for trying to use therapies like CAR T to try to eradicate a disease like MPNs without cleaning out the bone marrow. They are being looked at in clinical trials now to start with as a way to prepare people at high risk of relapse for bone marrow transplant. So people say, okay, well, CAR T may be helpful, but the limiter is that then you really would need a transplant because the bone marrow will be clean. So that's exactly what's being looked at first. CAR T followed by bone marrow transplant. Now, fortunately, we have many wonderful scientists in the world, and they're working exactly on trying to see, well, is there a way to do CAR T that is more specific to the cell in question so that we don't need to go through that extreme of a bone marrow transplant in addition to going through the CAR T. So a lot of research ongoing, but this is one of the reasons why this is not yet a solution for these diseases. So as you'll see headlines to say, cure for leukemia, new cure for leukemia, all that sort of thing, a lot of that has been referring actually to this type of work. So it's not a cure for your diseases yet, but it's not to say that the advances made there may not lead to one. Now, what about other targets? This is an example here of just some of the other types of targets that were presented at the American Society of Hematology meeting in 2017. So people are looking at a whole variety of different angles. We have made progress. We have ruxolitinib, we have interferons, we have things that have made a benefit, but we know that we still have room to grow. We still have many opportunities to better control these diseases and hopefully eradicate them. One such example of another drug that is in development, one that I and Claire and others are involved with, is an agent that works on this process of cell death or apoptosis, and is a drug from Roche called idasanutlin. And this is trying to work through the p53 pathway, another pathway involved with these diseases. There's a study that John Mascarenhas presented, the early study early on for the American Society of Hematology, both this drug alone or with interferon. And they showed some benefit, both in the people using it alone or with interferon, in people with more refractory PV. Of note, they had some good responses from a molecular level, again, suggesting this a completely different approach might be beneficial for people with MPNs, again, alone or in combination, but a completely separate approach that, again, may be combined in a range of ways. We work on testing novel approaches like this as part of a group we have in the U.S. called the MPD Research Consortium, led by my colleague Ron Hoffman. We have projects that focus on the biology and the discovery science of MPNs, from Ross Levine, from John Crispino, from Ron Hoffman, and then we have a collaborative group. You've seen some of the prior studies that work along with our cores for testing new therapies. It's an example here of just several different pathway type approaches that are based in the laboratory that are being worked on through the MPN Research Consortium for patients with myelofibrosis. Now, what about gene editing or CRISPR? This is another one that has much discussion. CRISPR, and this is why we use acronyms, stands for Clustered Regularly Interspaced Short Palindromic Repeats. Now, not the sort of thing that's just going to roll off the tongue at a cocktail party. But suffice it to say, this is a way to go in and try to repair a gene that is damaged. And it specifically came out of a system that was present in bacteria from to try to help protect it against viral infection. So this is what this actually looks like, a CRISPR-Cas9. Now what this is a way to try to correct deficiencies in genes. And the technical aspects, I'm probably not even the right person to give the most technical talk on CRISPR. But again, there's a gene, and let us edit it. Now, what are the positives and the negatives with this? So what has been done with this in MPNs? In a lot of ways, this created great enthusiasm. MPN patients have some key genes that we know are involved, JAK2 or CALR or MPL or others. If we could go in and cut out the bad gene and replace it with a good gene, wouldn't that be great? So there's been research that certainly has been done around this one. It has been successfully able to be used in the laboratory to create MPN-like phenotypes in the laboratory. They have been able to engineer mice with MPN mutations. It has been used in the laboratory to learn more about MPNs. And it has been used to repair in the lab setting the abnormal gene in patients with MPNs. So I've mentioned a lot in the lab because it really has not yet been tested or proven to be safe and effective in human disease. Now the pluses is that this can be used to edit a gene. And MPNs are genetically driven diseases. The minus is that it may harm other genes while it's in there trying to correct the right gene. The second part is that MPNs are not diseases of a single gene, but we think that in many individuals there's more than one gene that may be affected. And there is a controversial part of CRISPR that is not related to our discussion, but there is a lot of controversy around CRISPR around editing of genes on an elective basis. I want my child to have blue eyes. I want this gene. I don't want that gene. Again, not relevant in terms of our discussion, but there is this other controversy around CRISPR. Now, this, just to give you an example, these are mutation profiles of patients with MPNs. And these are colorful charts, but what these show is people might have one abnormality, but they might have multiple. So you see an A there, the people that have JAK2, but then how it correlates with people also having ASXL1 or TET2 or DNMT3A, Sybil, SFB31, etc. So a lot of genes, there's a lot of complexity. We may not have all the genes yet identified. So it still remains possible, even if we could wave our wand and JAK2 V617F was now no longer JAK2 V617F, there may be other genes that are driving the disease. Or if we take that one gene away, but one of these others is present, the disease might become a worse disease. So it's an exciting technology, it's important, but this is part of the reason why is this not yet ready in clinical trials. There are multiple ways this might be harmful if it's not done correctly. Currently, there are 18 trials of CRISPR being used in the US, very few in the grand scheme of things. Some of these have been used currently in HIV-associated malignancies and HPV-related malignancies. So these are ones with very specific virally based cancers as origins, which are felt to be perhaps the most linked to being able to be treated by this. And finally, I'll speak at something of passion for my group, which is non-pharmacological care. Again, think a lot about in terms of intensive therapies, but also we try to think about with long-term chronic illnesses, how can we help in other ways? Our group has been involved in trying to say, okay, you're on your medical therapy, you're not feeling 100%, how else can we help? And there have been efforts that have been going on in yoga, meditation, nutrition, dietary interventions, or cognitive interventions. So we performed, some of you may have participated in this, an online yoga study, yoga specifically designed for MPN patients, patients randomized to either yoga or a wait list control. We were able to demonstrate significant improvements in a variety of issues, in particular mood and depression associated with the disease, as well as issues such as improvement in pain, in sleep, as well as issues of intimacy. In addition, we have partnered with our colleagues in psychiatry and psychology around something called ACT, Acceptance and Commitment Therapy. This is, in short, a mindfulness program of just trying to deal with the uncertainty that comes with having a difficult disease. And with this sort of technique has been very helpful in a variety of chronic conditions, as well as in chronic cancers. Finally, what about diet? There's rarely a patient that doesn't ask me about, should I modify my diet because of my MPN? And in general, we say a healthy diet means a good healthy diet, whether you have an MPN or not. But there is great interest to see, are there specific things, particularly as they relate to inflammation, given that we know that the basis of inflammation for some MPN symptoms and progression, should we do something different? So we have been working to develop a platform to better develop, be able to share with patients and track whether if we did a dietary intervention, is it helpful, how is it helpful, and how do we learn from that? So I work with my colleague who's joined me in Texas, Robin Scherber, who really, her area of focus is learning about the biology of MPN symptoms and how, as we try to improve them, it teaches us more about both the disease as well as how we help quality of life. So I'll leave you with these conclusions. There's been rapid evolution of new immunotherapy-based treatments for cancer. They're not quite ready for MPNs, but they likely will be. And it may not be this generation, but it may be the next. But the lessons learned from that will end up bearing fruit. CAR T will likely impact transplant first, but may well evolve as that technology evolves to be more relevant across the board. There are many pathways in addition to the JAK-STAT pathway that are being investigated. CRISPR is already making an impact on us better understanding MPNs. But as a therapy that we use in the clinic, I think there are still several key technological advances that still have to occur. And non-pharmacologic therapies we hope to develop into a toolkit of resources that people will be able to access along with their healthcare providers that will hopefully complement the pharmacologic therapies that we have. So I'll share with you here we have a multidisciplinary MPN quality of life study group between both my institution as well as my former colleagues at Mayo Clinic, Arizona State, and the University of California at Irvine. And with that, gladly open it up to any questions.